Hi, everyone, and welcome to today's lecture session. My name is David Odige, and today we'll be exploring a comprehensive guide to medications used in hypertension, coronary artery disease, stable angina, and heart failure. Throughout this session, we'll break down major drug classes, their mechanisms, clinical uses, side effects, and most importantly, the nursing considerations that guide safe and effective patient care. To begin, let's define hypertension. The term hyper means high or above normal, and tension refers to pressure. So hypertension simply means high pressure within the blood vessels. Understanding how various medications lower blood pressure helps us provide safer, more informed care for our patients. Next, we explore adrenergic inhibitors, which work by reducing sympathetic nervous system activity. First, central alpha 2 agonists, such as clonidine, guanfacine, and methyl-dopa. These agents decrease sympathetic outflow, causing vasodilation and reducing systemic vascular resistance. They're used for hypertension, but side effects include sedation, dry mouth, and rebound hypertension if stopped abruptly. As nurses, we must monitor blood pressure and heart rate, caution patients not to stop the medication suddenly, and help manage dry mouth with gum or candy. Next, alpha 1 blockers, including doxazocin, prazosin, and terazosin. They cause peripheral vasodilation and are used for hypertension and BPH. Orthostatic hypotension is a major concern, especially with the first dose. Teach patients to take it at bedtime and rise slowly. Phentolamine is a short-acting alpha-1 blocker used for pheochromocytoma or managing extravasation from vasoconstricting medications. Monitor blood pressure closely and remember it is intended for short-term use only. Next, beta blockers, which lower blood pressure by decreasing heart rate, cardiac output, and renin release. They're used for hypertension, heart failure, and post-MI management. Watch for bradycardia and fatigue, and remember that non-selective beta blockers are contraindicated in asthma. Finally, we have mixed alpha beta blockers, such as carvedilol and labetalol. These reduce blood pressure, heart rate, and systemic vascular resistance. In use, especially for hypertensive crises, keep patients supine and monitor for orthostatic hypotension. Now let's move on to ACE inhibitors. Medications like lisinopril, enalapril, and captopril block the conversion of angiotensin I to angiotensin II. This results in vasodilation, decreased afterload, and improved kidney protection in diabetes. Key side effects include dry cough, hyperkalemia, elevated creatinine, and angioedema. ACE inhibitors are contraindicated in pregnancy and bilateral renal artery stenosis. ARBS, such as losartan and valsartan, block the angiotensin II receptor. They have similar benefits, but without the dry cough. Monitor potassium levels and kidney function and avoid combining ACE inhibitors and ARBs in renal disease. Calcium channel blockers reduce calcium entry into vascular smooth muscle and cardiac cells and are divided into non-dihydropyridines and dihydropyridines. Non-dihydropyridines, such as diltiazem and verapamil, slow AV conduction and decrease heart rate, making them useful for arrhythmias as well as hypertension. Monitor for bradycardia, dizziness, and constipation. Dihydropyridines like amlodipine and nicardipine primarily cause vasodilation. These are effective for hypertension and hypertensive emergencies. Monitor blood pressure closely and avoid short-acting nifedipine sublingually due to risk of dangerous hypotension. Direct vasodilators work by relaxing arterial smooth muscle. Phenoldiprem is given IV for hypertensive crises and causes both systemic and renal vasodilation. It may increase intraocular pressure, so monitor in patients with glaucoma. Hydralazine is used for hypertensive crises and resistant hypertension. However, it may cause reflex tachycardia and a lupus-like syndrome. Minoxidil, another potent vasodilator, is reserved for severe hypertension. It may cause fluid retention and excessive hair growth. These drugs often require combination therapy with beta blockers or diuretics. Here we have two potent IV vasodilators. Nitroglycerin, which dilates both veins and arteries, is especially useful when hypertension is accompanied by myocardial ischemia. Continuous BP monitoring is essential. Sodium nitroprusside produces rapid arterial vasodilation but carries the risk of cyanide or thiocyanate toxicity, especially in renal or hepatic impairment. This medication must be protected from light and monitored continuously using an infusion pump. Now let's discuss diuretics. Aldosterone receptor blockers, such as spironolactone and eplerenone, spare potassium and help treat hypertension and heart failure. Watch for hyperkalemia and avoid potassium supplements. Loop diuretics, including furosemide and bumetanide, are powerful diuretics that excrete sodium and chloride in the loop of Henle. They're used for edema and renal impairment, but may cause hypokalemia, ototoxicity, and hypotension. Potassium-sparing diuretics like amiloride and triamterene help prevent potassium loss. Monitor labs closely to avoid hyperkalemia. Thiazide diuretics such as hydrochlorothiazide decrease sodium reabsorption and lower systemic vascular resistance. They are first-line therapy for hypertension. Monitor for hypokalemia, hypotension, and hyperuricemia, especially in patients with gout. The final medication here is the renin inhibitor aliskiren, which directly blocks renin activity. It lowers angiotensin I and OI levels. Avoid combining with ACE inhibitors or ARBs in renal disease and monitor potassium and renal function. Combination antihypertensive therapy improves adherence and provides multi-mechanism control of blood pressure. Examples include ACE inhibitor and diuretic, ARB and calcium channel blocker, and ARB and diuretic. These medications share risks such as hypotension and electrolyte imbalances. As nurses, we monitor blood pressure, kidney function, and potassium levels while reinforcing medication adherence. Combination drugs like angiotensin receptor blocker plus calcium channel blocker plus diuretic offer a triple mechanism for resistant hypertension, causing vasodilation and volume reduction. Side effects include hypotension and electrolyte imbalance. Beta blocker plus diuretic reduces cardiac output and volume, useful for hypertension but may cause bradycardia. Calcium channel blocker plus angiotensin converting enzyme inhibitor combines vasodilation with renin angiotensin aldosterone system inhibition. These medications simplify treatment plans but require close monitoring for hypotension, electrolyte imbalances, heart block, or bradycardia. Now we enter chapter 37, focusing on coronary artery disease and stable angina. We'll examine medications that improve cholesterol levels, reduce angina symptoms, and prevent progression to acute coronary syndromes. First are medications that reduce cholesterol production. Statins remain the cornerstone of lipid control. They lower LDL, increase HDL slightly, and help stabilize atherosclerotic plaques. Side effects include liver enzyme elevation and muscle pain, which can rarely progress to rhabdomyolysis. Monitor liver function and educate patients to report muscle symptoms. Niacin decreases LDL and triglycerides while increasing HDL. Flushing is common and can be reduced by taking aspirin beforehand. Bempedoic acid, an ATP citrate lyase inhibitor, lowers LDL and is useful for patients intolerant to statins. Use cautiously in patients with gout or tendon disorders. Fibric acid derivatives like fenofibrate and gemfibrozil are taken orally, either daily or in divided doses. They reduce very low density lipoprotein synthesis, lowering triglycerides and low density lipoprotein while increasing high density lipoprotein. Commonly used for hypertriglyceridemia and low high density lipoprotein, they may cause gastrointestinal upset and elevated liver enzymes. Caution is advised when used with statins, warfarin, or antihyperglycemics omega-3 fatty acids, including icosapent ethyl and omega-3 acid ethyl esters, are taken orally twice daily. They reduce triglyceride synthesis and secretion, used for severe hypertriglyceridemia and as adjunct therapy for coronary artery disease. Side effects include arthralgia and bleeding risk. Caution is advised with anticoagulants, and patients should be educated on bleeding risks and advised to take with meals. Next, bile acid sequestrants, such as cholestyramine, bind bile acids, increasing LDL clearance. They may cause constipation and interfere with other drug absorption, so advise patients to take other medications at least 1 hour before or 3 to 4 hours after. PCSK9 inhibitors like alirocumab lower LDL profoundly and are administered subcutaneously every few weeks. Teach patients proper injection technique and monitor LDL levels. Ezetimibe, taken orally once daily, inhibits intestinal cholesterol absorption, reducing low-density lipoprotein and increasing high-density lipoprotein levels. It's used for hypercholesterolemia, either alone or with statins. Side effects include mild gastrointestinal upset and headache, contraindicated in liver disease when combined with statins. Monitor liver function and educate patients on adherence. For stable angina, medications aim to reduce myocardial oxygen demand and improve blood flow. Nitrates dilate veins and coronary arteries, relieving angina. Teach patients proper sublingual use and the need for a nitrate-free interval to prevent tolerance. Beta blockers decrease heart rate and contractility, making them first-line therapy for chronic stable angina. Monitor for bradycardia and hypotension. Calcium channel blockers relieve angina by vasodilation and reduced workload, especially useful if beta blockers are contraindicated. Ranolazine reduces intracellular calcium and decreases myocardial oxygen demand. Monitor QT interval and electrolytes. Aspirin and clopidogrel prevent platelet aggregation and reduce the risk of acute coronary syndromes. Monitor for bleeding. Statins stabilize plaque and reduce LDL, making them essential for CAD management. Our final chapter covers heart failure, focusing on medications that reduce symptoms, improve functional status, and reduce mortality. Heart failure management includes medications like ACE inhibitors, such as benazepril and enalapril, which block the renin-angiotensin-aldosterone system to reduce afterload and slow ventricular remodeling. They are first-line treatments in heart failure with reduced ejection fraction to reduce mortality. Monitor blood pressure, renal function, and potassium levels, and educate patients on potential side effects like hypotension and persistent cough. AC inhibitors like benazepril and enalapril block the renin-angiotensin-aldosterone system, reducing afterload and slowing ventricular remodeling. They're first line for heart failure with reduced ejection fraction, reducing mortality and symptom. Side effects include hypotension and cough. Angiotensin II. Receptor blockers, such as losartan, offer an alternative for ACE inhibitor intolerant patients. Sacubitril/valsartan, known as Entresto, combines neprilysin inhibition with ARB therapy. It reduces mortality but should not be used within 36 hours of an ACE inhibitor. Beta adrenergic blockers like bisoprolol, carvedilol, and metoprolol Succinate reduced sympathetic nervous system activity, lowering heart rate and afterload, and reversing remodeling in chronic heart failure with reduced ejection fraction. Side effects include bradycardia and fatigue. Start with a low dose, titrate every 2 weeks, and monitor heart rate, blood pressure, and heart failure symptoms. Diuretics improve symptoms of fluid overload. Loops are potent, thiazides are mild, and spironolactone is potassium sparing. Monitor electrolytes, kidney function, and daily weights. SGLT2 inhibitors like dapagliflozin act as osmotic diuretics, increasing glucose excretion and reducing cardiovascular death in heart failure with reduced ejection fraction. They are used as adjuncts in heart failure with reduced ejection fraction with or without diabetes. Side effects include dehydration and infections. Monitor volume status and renal function and educate on infection signs. Vasodilators such as nitrates and hydralazine decrease preload and afterload, improving symptoms in heart failure with reduced ejection fraction, especially in Black patients. Monitor blood pressure and heart rate, and be cautious of hypotension and toxicity. Morphine, an opioid, provides vasodilation, reduces preload, and alleviates anxiety, aiding symptom relief in acute pulmonary congestion and acute decompensated heart failure. Watch for respiratory depression, hypotension, and sedation. Anticoagulants like warfarin and direct oral anticoagulants prevent thromboembolism in heart failure with ejection fraction under 20% or atrial fibrillation. Monitor international normalized ratio and educate on bleeding risks. Finally, antidysrhythmic medications are used as indicated, requiring close ECG and electrolyte monitoring. Thank you for your attention. We hope this presentation has enhanced your understanding of heart failure management and the critical role of medications in patient care.